So I want to thank the Peripheral Neuropathy Association and PAM Labs for asking us to do this talk today on diabetic peripheral neuropathy. I'm Dr. Todd Levine. I'm a neurologist out of Phoenix, Arizona at the Banner Good Samaritan Peripheral Neuropathy Clinic. And the second half of this talk will be joined by Dr. Jacobs out of St. Louis University. I thought what I'd try to do during the talk today is to go through the different variety of symptoms that patients can have who suffer from diabetic neuropathy. And as a neurologist, our first stop when we start to see somebody is really to try to figure out what the problem is. And interestingly, a lot of the symptoms of neuropathy can also masquerade as other symptoms from other diseases. So it's very important to be able to sort out, do we think this is really coming from the peripheral nerves, or do we think this is coming from another cause? It's also very important to understand the different types of manifestations when we talk about diabetic neuropathy. So it's not just affecting the feet, and I'm going to try to take you through those types of symptoms as well. So when we talk about the peripheral nervous system, what we're talking about are the nerves as they leave the spinal cord on the way out to your arms and legs, and then the nerves that start in your arms and legs and go back to the spinal cord. We draw a distinction between the peripheral nervous system and the central nervous system in neurology, so that the central nervous system are the nerves that are made up of the brain and the spinal cord. And the diseases that affect the brain and the spinal cord are very different than the diseases that affect the peripheral nerves. And you can see from this slide that the peripheral nerves control a lot of different functions. So they control things that have to do with your heart rate, with your digestion, and we're going to go through the way in which diabetic neuropathy can really affect all of those different parts of your body. So when a doctor says that you have peripheral neuropathy, what they're referring to is any disease that can damage these nerves in the peripheral nervous system. And that can be diabetes, but it could be vitamin deficiencies, it can be immune system problems. There's really a host of different diseases. And what's important to understand is that nerves really work like telephone wires. So if you exist let's say in St. Louis, and you pick up the phone and you call Boston, that connection between St. Louis and Boston is very much like the connection your nerves make from your feet to your head. So if you pick up the phone and you hear static, that's what the patient feels with neuropathy. They're feeling the static of these sick nerves giving off abnormal discharges. But just like with the telephone, you don't know necessarily where that damage is coming from. So if you're in St. Louis and the phone is staticky, you don't know whether it's your end of the phone or Boston or somewhere in between. So that first step for a neurologist is to try to figure out where these nerves are damaged. The second thing to understand is that when we describe a nerve, say a nerve that goes to your hand for carpal tunnel, for example, which we might call the median nerve, that would be like on the left side of the slide here. But that nerve, we actually is made up of hundreds or thousands of individual axons. And as that nerve gets sick, all these little purple staining areas, which are the individual axons in the nerve, start to die. And so you end up with a nerve that has very few axons left inside of it. And in this case, for example, even the remaining axons may not be functioning correctly. And it's that static or those abnormally functioning axons that we pick up as the pain, burning, stinging, stabbing sensations associated with diabetic neuropathy. If you look at an individual axon, that axon is actually made up of two parts. So if you look at the top of this slide, you can see sort of a dark staining structure running through the middle, and then this kind of clear translucent area around it. So the axon, or the wire that conveys the electrical impulse, is actually right in the middle of this. And then wrapped around that, we have what's called myelin. And the myelin is like an insulation for the nerve. And what it does is it allows the nerve to conduct electricity very quickly. So we need our nerves to work very, very quickly. And so the more myelin that's wrapped around the nerve, the faster the nerve conducts electricity. So if you look at the picture on the bottom, you can see that the axon is actually still intact, but there's no myelin left around that nerve. So when the nerve signal traveled down and hit that spot, it would slow down. If it slowed down too much, it might not get through, but otherwise it would try to slowly make its way through. And the person would perceive that that nerve isn't working correctly because it's not working at the normal speed that it's supposed to. So what symptoms do people typically complain of if they have neuropathy? So they complain of anesthesia, which is actually a loss of sensation. And as I explain it to patients, that's those dead nerves. So if you think back to that picture of that nerve fascicle where there were lots and lots of dead nerves, where the nerves are dead, they can't convey any information, and so the person perceives a loss of sensation. But then inside of that fascicle, there also were some sick nerves, and those sick nerves give off abnormal discharges. And the nerves are kind of unstable. It's like a frayed wire. And so as those nerves give off these abnormal discharges, the person perceives burning, stabbing, tingling. Patients with diabetes will often say that when they get into bed at night and they pull the sheets up over the toes, it feels like somebody took an ice pick to their toes. Well, for the rest of us, that's really comfortable and cozy, but these nerves are functioning incorrectly. If the neuropathy gets bad enough, it can start to involve motor function, in which case the patients can have weakness. And then because of the loss of sensation, balance problems are a very common complaint associated with diabetic neuropathy. With the loss of sensation to the feet, and we're going to hear more about this from Dr. Jacobs, it's very important to protect the feet. So this is just one example of a bad infection. And so podiatric care for any patient with neuropathy is really, really vital. So you have to watch toenails, you have to learn to inspect the bottoms of the feet because you can't feel the cellulitis or the infection setting in because of the loss of sensation. And there's a huge number of amputations, more than 40,000 every year, that are related to patients that have neuropathy, and diabetic neuropathy is probably the leading cause of that. So once we determine that a patient has neuropathy, as a neurologist, our job is then to try to figure out why they have neuropathy. And sort of the disappointing news in this is that about 50% of the cases that we see, we won't be able to figure out why. So we call those idiopathic, or the joke is that we're too much of an idiot to figure it out. The second most common cause is diabetes or even early diabetes, what we call impaired glucose tolerance, probably makes up about another 25%. Some form of vitamin B12 deficiency, probably 5 to 10%. And then patients that have had toxic exposures, so heavy alcohol drinkers, patients that have had chemotherapy. There's a significant number of patients that inherit neuropathies, and then certain infections like HIV commonly cause neuropathy. The other group of diseases that cause neuropathy are autoimmune diseases. So here a patient's immune system, which is supposed to fight bacteria and viruses, actually starts to attack their own nerves. And this is another important group of diseases to recognize because those are often treatable. So if you're having these types of neuropathic complaints, the first thing to do is to get that evaluated. And again, the key thing is to confirm that it's a peripheral neuropathy. So if you think about that connection between St. Louis and Boston, and anywhere along that connection can cause the same symptoms. So you can complain of pain in your feet, even if the pain is compressing, or even if the problem is compressing the nerve in your back, or if it's a problem in your brain. So there's a lot of different mimics of peripheral neuropathy. So the first and most important thing is to confirm that it is a neuropathy. The second thing is to try to confirm whether or not the disease process is affecting the myelin, the insulation around the nerve, or the axon. And we do that through tests called nerve conduction studies. And then we do a bunch of blood tests to look for common causes. If we don't find the cause, if we don't find diabetes or B12 deficiency or a cause that we can identify, we sometimes go on to more esoteric tests. So we can look for specific antibodies in the blood, and in some cases we'll even do a muscle and a nerve biopsy to see if that can tell us what's causing the problem. And this is just an example. If you look at the bottom of the slide, these are nerve conduction studies. So we stimulate a nerve, and you can see kind of a nice response. But if the nerve has been affected in such a way that the myelin is damaged, what we call demyelinated, then you can see that same response takes about 3 times as long to travel. So affecting that myelin, we can see slows down the speed with which the nerve conducts the electricity. So what I'm going to try to do then is take you through the gamut of symptoms that diabetic neuropathy can cause. So the first is that it can cause leg symptoms. One of the most important things that I ask every patient that comes through with neuropathy is when their symptoms are worse. And almost universally, a patient's symptoms are worse with neuropathy when they're at rest. So when there's things going on, when there's other sensory stimuli, they don't notice the pain as much. So when pain is worse when you lay down at night or sit down, that's usually peripheral neuropathy pain. If the pain is worse when you're walking, then there's a host of other things that can cause it. So you can have compression of the nerves in your back, you can have difficulty with the blood supply, and you can have problems even in the foot themselves that will cause these types of problems. So that's a very important question to kind of keep in mind. Patients can have sexual symptoms with neuropathy because of the loss of sensation. This is often a very common problem associated with patients, particularly with diabetic neuropathy, because the vascular supply will also be impaired. So men can have erectile dysfunction and women can have sexual dysfunction as well. This is something that many doctors unfortunately don't ask about and many patients often don't bring up, but it's a very significant impact on a patient's quality of life. Bladder symptoms are not that common with neuropathy, but some neuropathies can lead to a loss of sensation, which can cause some overflow incontinence. But what I typically tell my patients with neuropathy that start to complain of incontinence, We know that neuropathy becomes more common as people get older, and unfortunately bladder symptoms become more common as people get older for a host of other reasons that have nothing to do with their neuropathy. So it's usually important to see a urologist, sometimes to get testing, what's called urodynamic testing, and to make sure that there's nothing wrong with the prostate or the bladder that's causing the symptoms. And then if not, then it may be related to the peripheral neuropathy. Particularly in diabetic patients, gastrointestinal symptoms are a big problem. So we talked about the peripheral nervous system controlling sensation, meaning the way the patients feel, and also controlling motor function, meaning the way that patients move. But the peripheral nervous system also involves what we call the autonomic nervous system. And this has a lot to do with your heart rate, your blood pressure, and also the way in which food moves through your gut. And so one of the very common problems in patients with diabetic neuropathy is to develop what's called gastric stasis, which means that their stomach just doesn't move very well. And that can cause bloating, can cause abdominal pain. In severe cases, it causes weight loss, and we even have to put patients on drugs to try to help their stomach move a little bit faster. So these are very common symptoms associated with the autonomic nervous system, and often these symptoms can even precede a lot of the pain in their feet that patients get with neuropathy. Likewise, the cardiac symptoms can sometimes be an early sign of diabetic neuropathy. And what happens is patients can't really control their heart rate or their blood pressure. So the most common symptoms are just lightheadedness, where patients stand up and feel like they're going to pass out or feel very swimmy-headed frequently, or actually have syncope, where they do pass out. Some patients will actually just have a lot of fatigue because their heart rate really can't keep up with their body's demands, or they can have palpitations where their heart rate actually races too quickly. So these can be evaluated through something called autonomic testing and a tilt table test. And we have to do a number of things here. So for patients that are really bothered with this with diabetic neuropathy, it almost goes against everything else you've heard about doctors tell you. So the problem here is actually that they can't get their blood pressure up high enough. And so these patients frequently pass out. So we stop their blood pressure medicines. As doctors, we tell them to take lots of salt and caffeine, all the things you wouldn't think to do, because what we're trying to do is actually to raise their blood pressure. In some cases, we actually even have to put patients on medications that specifically do raise their blood pressure, or else they'll keep passing out. Swallowing problems are also very common in patients with neuropathy. So this can lead to choking when they eat, in severe cases can lead to weight loss, and often has to be evaluated by a speech therapist. Like with the incontinence, there's a lot of other reasons why patients can have swallowing problems. So the important thing here is to be aware that they can be a symptom of neuropathy. But if they do present, not just blame it on the neuropathy, but actually to look for other causes. And you can see here that neuromuscular disease really comprises only about 6% of the cases of people that have trouble with swallowing. So it's a rare occurrence, but because diabetic neuropathy is so common, we do see it not infrequently. But it's important to make sure you don't have any of these other causes for the swallowing problems. Emotional side effects are a real problem. So as patients deal with chronic pain, it is just not much fun. And so about 30% of patients with chronic pain related to peripheral neuropathy will develop depression. This is a very, very common symptom. There are ways to try to treat this. We think that exercise can actually help with depression. There's a non-pharmacologic therapy called cognitive behavioral therapy, where neuropsychologists will teach people how to deal with pain and to cope with their pain better. But very frequently we do resort to placing patients on antidepressants to try to treat the depression that comes from having to deal with pain on a very daily basis. And then one of the other big problems for patients with peripheral neuropathy is sleep dysfunction. So as I said, it's very common that when you lay down at night, that's when the symptoms of peripheral neuropathy, and particularly diabetic neuropathy, are going to be worse. So if your feet feel like they're on fire, it's very difficult to actually be able to fall asleep. There's also a very large cross-reaction between patients that have peripheral neuropathy and patients that have restless leg syndrome. So restless leg syndrome is a sensation where patients feel like they have to get up and move around when they're trying to fall asleep, or else they get this dull, achy, uncomfortable feeling in their legs. So for those poor patients, they've got burning and tingling in their feet, as well as this dull, achy sensation, and they're frequently getting up every hour, every 2 hours to move around. And obviously that causes a lot of sleep dysregulation. The problem with the sleep dysregulation is that we know that if you don't get good sleep, your pain is better. We also know that if you don't get good sleep, your mood is worse. And so it's very important to try to treat the sleep dysfunction that's associated with this to try to improve a patient's quality of life. My final slide then is just to kind of go sort of an overview of the treatment for painful neuropathies. And for the most part, these kind of break into 3 or 4 main categories. So in terms of FDA-approved medications to treat the symptoms of neuropathy, it really boils down to 2 medications. There's a medication called Lyrica, or pregabalin, and that has an FDA indication to treat the pain associated with diabetic neuropathy, and a medication called duloxetine, or Cymbalta. It has the indication to treat the pain associated with neuropathy. These 2 medications don't do anything to improve the overall nerve function, but they do make a patient's pain level significantly better. There are lots of side effects to these medications, and about 1/3 of the patients that take them really don't tolerate them very well whatsoever. Neurontin is an older sort of prodrug of Lyrica, and that's used frequently as well. And then an older antidepressant we use are the tricyclics, so amitriptyline or nortriptyline. These medications are very effective. They have the other nice advantage of actually being able to make patients sleepy. So when you take them at night, it improves the pain and also helps the patient sleep. In terms of data to look for evidence of improved nerve function, there's actually 3 supplements that are out there that have some nice data that have been shown to improve nerve function. So alpha-lipoic acid, acetyl-L-carnitine, and then a product called Metinex, which contains a form of B12, B6, and folic acid, has been shown to improve nerve function as well. The nice thing about these, again, is that we're really trying to do something to reverse over the long run the progression that we know that comes from diabetic neuropathy. So untreated, most patients with diabetes will go on to develop neuropathy, and most patients with diabetic neuropathy will progress and the neuropathy will get worse. If all of the above don't work, many patients unfortunately do end up on long-acting pain medicines such as narcotics and opioids. This is a difficult problem because with time, the amount of medication that a patient needs actually increases. And so there's a long-term dose escalation. And there's a lot of theories these days that say actually that many of the opioids actually can make neuropathic pain worse. So patients may initially feel better with the medications, and over time the pain can actually get worse. And there's a lot of very good theories that relate to the fact that there's changes in the brain. And so we try to avoid these medications as much as possible. And so with that, I will stop, I think, and pass it over.
This is Dr. Alan Jacobs, and I'm going to follow up with Dr. Levine's discussion. And I was asked to focus primarily on the lower extremity manifestations of neuropathy and problems associated with that. Of the identifiable diseases that are responsible for neuropathy in the legs and feet, undoubtedly diabetes and people that have what's commonly referred to as pre-diabetic state or impaired glucose tolerance are the most common causes for neuropathy. With all the study that goes on, we can identify differences between diabetic nerves and the nerves of patients that don't have neuropathy, but it's difficult to determine exactly what the specific cause of diabetic neuropathy is. It probably is a number of factors. We have 3 goals in looking at diabetic neuropathy. Number 1 is the minority of patients, and those are the patients that have burning or shooting, painful neuropathy, what we call positive symptoms, and that actually is the minority of patients. What we want to do is try to prevent continuing deterioration of those nerves, and if we can all possible reverse this and try to grow nerves and improve sensation in the feet of our diabetic patients. Everyone worries about their feet, and rightfully so, if they are suffering from diabetes. And if we look at the causes of infections in feet of diabetic patients, other than poor control of diabetes, neuropathy is the most common factor associated with patients who have infections in their feet. Obviously, smoking, poor circulation, what's called peripheral arterial disease, are also factors. But number 1, other than bad control of your diabetes, is actually neuropathy itself. As Dr. Levine mentioned, there are many signs and symptoms of neuropathy. And while we can talk about shooting pains and burning pains and aching and throbbing, the most serious complications in neuropathy occur in patients who have lost sensation. That is, they have numbness in the foot. And this is where we need to concentrate in trying to prevent serious problems in the diabetic patient. If we look overall at patients that have diabetes and have neuropathy, only as much as 20, maybe 30% at most, patients that have neuropathy actually require pain-relieving medications, such as Dr. Levine just mentioned. the antidepressants, the anticonvulsant medication, so forth and so on. But when we see patients who come into our office that have, for example, here, you see an ulcer, a break in the skin, and this was likely a callus, a pressure spot. And the problem occurs because these patients lack feeling. They've lost sensation in their feet, and they actually have numbness. And numbness, or lack of feeling, constitutes really the major problem in diabetes with neuropathy, and constitutes the majority of patients who do have neuropathy. If we look at the risk of an amputation in a diabetic patient, and we know that of all the diseases that we can account for, diabetes is the disease that it causes more amputations than any other disease. The number one factor leading to amputation is neuropathy. We have patients that have abnormal functions of their feet. They have various deformities in their feet, and we have patients with peripheral vascular disease, poor circulation. But when all is said and done, the number one factor that's responsible or associated with amputation is neuropathy, and that is why we want to concentrate so much on neuropathy. What neuropathy does is illustrated here. It takes away our perception that we have a problem. Here, for example, we could see some toenails that hopefully the people listening to this webinar would never let get to this point. And you would say, well, how would you ever get something like that in a shoe? But if you've lost sensation in your feet, you don't realize that this is putting tremendous pressure on that toe, breaking down the skin. Calluses become ulcerations. Long toenails that are uncared for dig into the adjacent toes. And here's a poor individual that lacks feeling in this foot, never felt any pain whatsoever. The toenails got very long. They dug into the skin at the adjacent toes. They got a secondary infection, and now this patient has gangrene. We have calluses that are pressure spots. Calluses on the bottom of your foot, areas of thickened yellow skin, are areas where there's more weight than the rest of that foot. If you had a callus, or if you had a nail that looked like this, or if you had a toe that was sitting up in the air, what they call a hammer toe, if you have normal sensation, you'd say, this hurts every time I'm in a shoe, I better get some bigger shoes or get somebody to take care of this problem. If you're a diabetic and you have neuropathy and lack feeling, none of these things hurt. The pressure of that toe rubbing on the shoe continues. You do nothing about it because you don't perceive that there's this pressure, and it results in a breakdown of the skin. And this is where these ulcers come from. So once again, we see simple everyday problems that are the cause of these ulcers and amputations. The fact that the patient has diabetes, they have neuropathy, they have deformities that are not appreciated because of the lack of feeling. That pressure continues and an ulcer develops. And once we have an ulcer or a break in the skin, we've opened up the body for germs to enter, and we get secondary infections with all the problems that can go along with the diabetic patient. In fact, we know that the majority of amputations that occur in people that have diabetes are preceded by the presence of an ulceration. 85% of the time, people that you meet that have lost a toe or part of their foot or a leg started with an ulceration that became infected and uncontrolled. So that it is important to control neuropathy as best we can and take care of these deformities because they will break down over time. Now, have we been successful in doing this? If you control your diabetes, if you are receiving routine evaluations, can you prevent amputation? This is the most recent study published in January of 2012 in Diabetes Care, showing that over this 10-year period, up to 2008, amputations in the United States have plunged tremendously. And while diabetic patients still have many more amputations than patients who don't have diabetes, the rate of amputations has fallen dramatically from 11.2 per thousand down to 3.9 per thousand. Why? Because people are seeking earlier care. They're seeing their podiatric physician and surgeon, their primary care physician, their healthcare providers, having their feet checked, and problems are being taken care of early. When we look at the etiology of these problems, we have, again, deformities in the foot that are unappreciated because there is neuropathy and lack of feeling. These deformities cause repeated injury of the foot against a shoe or on the ground. Once we get a wound, the vascular disease, the poor circulation makes it more difficult to heal that wound, and this is where these problems come from. We spoke a lot about burning and tingling and shooting pains. But if we look at a patient that has an ulcer on the bottom of their foot, almost always it is painless, because the majority of disease, the majority of problems that lead to amputation in diabetic patient occur in patients who do not have pain. They have anesthesia and lack sensation. They lack the gift of pain. They lack the protection that pain would offer you to say, hey, there's a problem down here. But there's more than just loss of sensation. Many diabetic patients have motor neuropathy, because just as you lose the nerve supply to your skin that gives you feeling, many diabetic patients lose the nerves that go to the muscles in their legs and feet. Sometimes this is reflected as just loss of an Achilles tendon reflex, but oftentimes, in fact, 50% of the time, patients have lost a substantial amount of the muscle in their feet. This results in the bones moving into abnormal positions because the muscles aren't holding things where they should be, and they develop deformities. Or they have what's called autonomic neuropathy, where patients lose, for example, sweat function of their foot. And you might say, well, what's the big deal? So my foot's a little bit dry. Well, unfortunately, that dry foot allows fungus germs, sort of an athlete's foot, to grow. Those germs then crack the skin, then the bacteria get in, and then we get a secondary infection again that could go on to some very disastrous problems. Motor neuropathy, again, the nerves that go to the muscles in the legs and feet. We have these kind of symptoms, people that complain about their knee feeling unstable, people that have difficulty standing for long periods of time, difficulty walking, difficulty going up and down stairs. Oftentimes we attribute these to bone and joint problems. We say, well, maybe it's an orthopedic problem, but many times this is due to the effects of loss of the muscles' nerve supply from motor neuropathy. In the foot, the muscles that are in the arch are the muscles that hold the toes down flat on the ground. And the average diabetic patient that is seen in the average podiatry office has lost 50% of the amount of muscle in their foot compared to a patient who has the same sex, same age, but does not have diabetes. So these muscles get weak, the toes come up in the air, they start rubbing on the shoe. The patient doesn't feel it because of the loss of feeling in their foot. When the toes come up in the air, they push the bones behind them down into the ground, so there's increased pressure in this area. Again, unfortunately, if you've lost sensation in the foot, you don't appreciate that increased pressure, and then the skin breaks down, so that this becomes a very, very significant problem. So we end up seeing feet that look like this, where the toes are popping up in the air. We see this toe starting to rub on the shoe, and the skin's becoming thick. We see a bunion here. Again, this will rub. This is where the problems come from. And again, if you had these problems with intact sensation, your feet would never look this bad. You would see someone and say, I need to do something about this. But unfortunately, if you lack sensation in the foot, you don't appreciate the extent of these deformities, and bad things happen, and eventually we start getting hammer toes, depression of the bones behind the hammer toes, and we get pressure spots here, pressure spots underneath. This is where the ulcers come from this motor neuropathy. And here's an example of a patient that has hammer toes. They have a lot of pressure on the tip of the toe because they're taking the weight on the tip rather than underneath the toe. It starts out as a callus. This would hurt somebody with normal innervation. The patient with neuropathy doesn't feel it, the pressure continues, and it breaks down into an ulceration. So when we see these different problems, again, the deformities are from lack of nerve supply to the muscles. This allows these deformities to occur. This increases areas of pressure in the foot. We don't appreciate that because of the loss of feeling, the sensory neuropathy, and this is where the ulcerations come from. And this is the job of a good healthcare provider, to look for these deformities. Here we see that dry skin because we've lost sweating in this foot from the autonomic neuropathy. The toes have depressed this bone down. There's increased pressure. We have a callus. The patient doesn't feel it because they've lost feeling in the foot, and now it's broken down into an ulcer. This is where the problems come from. Dr. Levine mentioned various manifestations of autonomic neuropathy, such as problems with bladder and GI function and so forth and so on. Autonomic neuropathy is yet another lower extremity type of neuropathy, meaning this is not the nerves that give you sensation. It's not the nerves that go to the muscles. These are the nerves that do things like go to the sweat glands, so we get this dry skin. Sometimes people get swelling of their feet, and we say, well, maybe it's bad veins, maybe it's my heart, maybe it's kidneys. But sometimes neuropathy actually causes swelling because it affects the veins and doesn't let the veins in the legs work properly. They sort of open up or dilate. The blood doesn't get back to the heart. and we have persistent swelling. So we see feet that look like this, again, dried up with callus tissue, and here we see an ulcer forming. And again, all this is occurring because of motor neuropathy deforming the foot, sensory neuropathy, meaning the patient has no pain with this, so they don't seek care, and then dry skin from the autonomic neuropathy. So how do we prevent these problems, and how do we cut them off early? And it's listed here for you. This involves detailed, regular foot examination, and you've got to be evaluated for risk factors. The number one risk factor being the presence of neuropathy, the second being the presence of vascular disease, and the third being deformity, because these deformities, when they're not appreciated because of lack of pain, cause skin breakdown, and then if we have poor circulation, once we get that ulcer, we simply cannot heal it. So it's a job of the healthcare provider to look for these deformities, detect that neuropathy early on, try to keep that neuropathy from progressing, and either get proper shoes or footwear for those deformities or have them corrected. And periodic examination and treatment of these feet is the reason that we have seen amputation rates drop dramatically. We can stand people on certain devices and measure, for example, temperatures, because we know that areas that are going to break down and ulcerate tend to have a higher temperature than calluses that aren't going to break down and ulcerate. We can look at a foot like this and see an area right here where clearly, although the patient has no pain, we see all this dry skin from lack of sweating, but here's a pressure spot. And we know if we don't get something in the shoe to get weight off of that area, that's going to go on and break down into an ulcer. Here we see a callus in the same spot in a different patient. Again, you can see how dry that skin is from loss of the sweat gland function, but this is going to break down into an ulcer, and you can see the very beginning of an ulcer right here. Again, because of neuropathy, patients do not have pain with these problems, and that's why careful screening, looking at patients for risk factors, and then trying to intervene is important. We can measure pressures, and as you'd imagine, this is a typical pressure mat, and the darker these areas are, the more pressure it is. And here we can see a dark black spot in this area, meaning this part of the foot is taking more pressure than the rest of the foot, and we've got to get something in that shoe or on that patient to protect that area from increased pressure, because that's going to become an ulcer. And again, this is something that's unappreciated. Now, can we do anything besides just correct these deformities? And the answer is yes. We've done a substantial amount of work with Medinex, which is L-methylfolate, methylcobalamin, which is an active form of vitamin B12, and pyridoxal 5-phosphate, which is an active form of vitamin B6. And these are biopsies from skin, and these little lines here are nerves in diabetic patients from their feet. And here's a patient, for example, that has substantial numbness in their foot, and with supplementation utilizing Medinex, we've been able to increase nerve density and actually regrow nerves into that skin so that this patient is no longer unprotected. The patient now has restored sensation. They appreciate those thickened nails. They appreciate that callus, and because of that, they're less apt to ignore these things. And we've been able to show in an initial study that a substantial number of patients, 73% of patients, actually are able to double their nerve count in their skin by simple addition of L-methylfolate, B6, and B12 in their active forms to their diet and help protect their feet from these amputations. So in summary, I wanted to speak to you today not about the painful neuropathy, but about the patients that have non-painful neuropathy with the nerves that go to the muscles, the fact that the foot loses sensation, the nerves that go to the sweat glands, because it's the non-painful neuropathy that results in the problems that result in amputation. And that risk evaluation of your feet should include an examination for the nerves that go to the muscles, the nerves that go to the sweat glands, evaluate you for lack of sensation, which many times you don't even appreciate is present, and then try to control the diabetes and utilize nutritional therapy such as Medinex in an effort to, at a minimum, stop the neuropathy from getting worse and hopefully cause a regrowth of nerves to restore some sensation to the feet.